Have a nice day, everyone, and good morning, everyone. My name is Domenico de Berardis, and I'm a psychiatrist and psychotherapist. I work in the real world everyday clinical practice, dealing with all type of patients with psychiatric disorder, because I work in the hospital, in the psychiatric ward of the hospital Giuseppe Mazzini in my town, that is Teramo. That is located in the Abruzzo region on the Mediterranean side of Italy. So I am very proud, very honored to give you this presentation, and I will warmly thank Professor Daria Smirnova for inviting me to give you this presentation. And I hope that you will enjoy what I will say, and I hope I will give you some practical instruments that are related to alexithymia and psychiatric disorders. My principal aim of this presentation will be to give you 13 reasons why, repeating the famous Netflix series, and why it is useful to evaluate alexithymia in our everyday clinical practice and research. I believe that great tribute and great thanks will be to Peter Emanuel Sifneos, this Greek psychiatrist that is always dealing with patients with psychosomatic disorders, and he wrote a lot of articles, a lot of papers, a lot of books about alexithymia and above all psychosomatic disorder, and he defined the word alexithymia. The word comes from the Greek language, alpha, a knot, lexis, words, and thymos, heart and emotions, literal meaning to have no words for identify or describe emotions that are, to date, the core of the alexithymia concept. After a great improvement and a great advance in the research about alexithymia was made by the Toronto group, and I refer to Professor Michael Bagby, Professor James Parker, and Professor Graham Taylor. They are very important persons in the research about alexithymia, and not only alexithymia, but also in other psychosomatic and psychiatric disorder. But they gained the merit to develop the first self-rated scale and the first, maybe most important scale to measure, to evaluate alexithymia in clinical context or in general population context. The first version was 26 item. It was called Toronto Alexithymia 26 scale. After revision, they eliminated the 6 items, and we have the actual version of the self-rated instrument to evaluate alexithymia that is called Toronto Alexithymia scale. It consists of 20 items and 3 subscales. But we will see this issue after in my presentation. But they improved and they introduced this instrument to easily measure and evaluate alexithymia in every kind of patient, but also in normal people or in people in the general population, starting the research of alexithymia in the community. It was very important for several reasons. I believe that the alexithymia construct is a complex construct that is not be described as a single entity. The alexithymia construct consists of several issues, dimensional issues that may be more or less prominent depending on the persons we have in front of. And it consists of emotional unawareness that comprehend difficulty identifying and describe emotions, a difficulty distinguishing between subjective emotions and somatic sensation of arousals that are maybe the real issue, the real core issue of alexithymia construct. But this is often accompanied with a concrete thinking, with a reduction of imaginative processes and a reduced daydreaming, between them, and an externally oriented cognitive style. Patients with high levels of alexithymia are often very concrete, have a poor access to their inner world, and so in psychotherapy they are very hard patients to manage, because when we try to deepen, to go deep in their inner world, they have no access to it, and so it's very difficult to manage with a person that is unable to distinguish, to identify, and to describe their emotions to the psychotherapist. This maybe is associated with social conformism, and patients, subjects with high level of alexithymia have a superficial adaptation to social reality. They adhere rigidly to usual roles, and unfortunately they have a lot of difficulties in intimate and social relationships, and have a poorer empathy than subjects with lower or no levels of alexithymia. They live badly than subjects with without alexithymia. It is very important to underscore. Several studies, very important studies about alexithymia were made by Henry Krystal. I often introduce Henry Krystal in my presentation that I give about alexithymia, because his book Integration and Self-Healing, and specifically his book on affect, trauma, and alexithymia, is a milestone, in my opinion, in the alexithymia research. Well, Eric Krystal personally lived the experiences of Nazi concentration camps. He observed other prisoners, he observed the reactions of other prisoners, and he saw that many of them had a sort of kind of blunted emotional response. But it was not a blunted emotional response that were only ascribable a probable PTSD, that may also be conceivable in a horrible situation as was the Nazi concentration camp. But many of them had no post-traumatic symptoms, were prisoner into the Nazi concentration camp, but reduced their capability to access to their inner feelings and inner emotions, and so develop what is today we can call a secondary alexithymia. Maybe hypothesizes that Nazi concentration camps prisoners experimented a state of hyperactivation when they faced with the horror and plague of concentration camps. But after, as a mechanism of defense maybe, or a result of this intense hyperarousal, similar to this present in post-traumatic stress, but quite different in its characteristics, they developed an emotional inhibition. It was developed, maybe, he said, for the sense of surviving, or for the sense of living. The only reason that was behind this emotional inhibition was trying to survive. And so, to survive them, they use this coping strategy. This coping strategy was also well described by an important Italian writer. He's called Primo Levi. Many of you surely know him. He died from suicide, but he described his sense of secondary alexithymia in several books he wrote after he was discharged. He was freed by the Nazi concentration camp in Auschwitz, and to cope every day when he returned to everyday life with this emotional inhibition. The fundamental of secondary alexithymia is that is often seen in response of traumatic events. Before developing post-traumatic disorder, one can develop a secondary alexithymia, and the presence of a concurrent PTSD and alexithymia is worsening each other, but it's worsening the outcome of PTSD, and this is very important to see. But alexithymia in newer, as you can say, newer conceptualization is primarily a disorder of an affective dysregulation. Alexithymia can be easily defined as an emotional regulation disorder. The core keys of alexithymia construct are the difficulty in identifying and discriminating to someone else our emotions, an impoverished ideation, and a concrete style, an outward-oriented style of thinking. But the great struggle that face everyday alexithymic individuals is often the ability to control negative emotions, because they cannot tolerate negative emotions or affects as boredom, emptiness, loss, anguish, depression, irritability, anger, and so on and so forth. And they cannot balance them with positive affects in an autonomous way. And this may be a very cause of concern in such subjects, because they can somatize these emotions, their emotions, or they have a behavioral at an outset, and they may develop suicide ideation and behaviors, they may act self-mutilation, they may use substances to reconnect with inner worlds or to feel sensation, but they often develop somatization, eating disorder, behavior disorganization, and often psychiatric disorders. We believe that the neurobiological underpinnings of alexithymia may be highly related to a dysfunction in the short circuit that has a key region in the anterior insula. The insula is a kind of gateway. The insula mediates the inner sensation that comes from our body, and they are decodifying this sensation and send to higher structures in the brain, such as the dorsomedial DMPFC, the anterior cingulate cortex, or the ventromedial prefrontal cortex, as well for affective working memory levels and high levels to decodive emotional concept and to appraise the situation. As well, there is an indirect connection with anterior cingulate cortex, dorsal anterior cingulate cortex, and there is a key region involved in motivation and action selection. We can hypothesize that the communication between anterior insula and all these regions are quite lacking or quite diminished. So the patient has a kind of loop that send back the information that comes from brainstem nuclei and body concerning body states in a loop that causes maybe alexithymia. This is maybe true, maybe even more true when the alexithymia is on high levels. Another hypothesis that is linked to the previous hypothesis I told before is the alexithymia stress hypothesis. Maybe we can hypothesize in this paper that we published several years ago that alexithymia may be linked to a chronic stress state. And alexithymia may be linked to chronic stress state per se, or through the development of symptoms, psychiatric, psychosomatic, or somatic symptoms, and also is related to higher suicide risk, and this may influence the chronic stress state, and the chronic stress states may reinforce symptom severity and suicide risk. But chronic stress state per se leads to a subclinical chronic inflammation state, an increase in C-reactive protein and production of cytokines. This being because there is, due to chronic stress states, a HPA dysregulation with increase in cortisol levels that are always at a high end of normal values in subjects with alexithymia, or even higher when they are facing an acute stress. And this is a vicious circle that may explain the characteristics and the peculiarity of alexithymia, its detrimental effects when is comorbid with a psychiatric disorder. Why it's useful, in my opinion, to evaluate alexithymia in the clinical practice? I will give you 13 reasons why, starting from a very funny, very important Italian movie that is called The Medico della Mutua. Maybe translates with the primary care physician, interpreted by a great Italian actor, Alberto Sordi. And he was facing with a classic symptomatic patient that you see depicted in this magnificent photo. That is Leopoldo Trieste, who is assisted by a beautiful wife, Adriana Giuffre, that she can't manage more the psychosomatic issues of her husband. And it was a fun movie. I believe there are also with subtitles or translated in English language, so I very advise to see them. It's very funny. The first reason is we have the Toronto Alexithymia scale, 20 items. As a screening tool, we have a cutoff of more or equal to 61 to identify subject at risk to have alexithymia, and is too easily to administer. There are 20 items that are describing the three core characteristics of alexithymia. The first factor is the difficulty identifying feeling factor. That is one of the most important, as well as the factor 2, the difficulty describing feelings. There are maybe the most relevant factors in Toronto Alexithymia scale. And there is also the factor 3, the externally oriented thing, that is quite important, but have a lower internal consistency and reliability than other subscales and other factors. But it's quite useful to administer, to have more information from. This is the overview of the Toronto Alexithymia scale, and that's what I said before. And the stereotypical thinking is quite similar to the concept of pensée opératoire that was introduced by Marty et de Musan in 1963. It's obvious that a self-rating scale has several limitations, the TAS 20. Overall, as above all, a poor internal consistency of the EOT subscale. It is maybe to administer to clinical in clinical situation with other rating scales that measure all features of depression, anxiety, or other psychiatric symptoms. and is always on self-assessment scale, so subject to biases that are all inherent in all self-assessment scales we used in everyday clinical practice. The TAS-20 can be administered to everyone, but not in the case of an intellectual disability, because it's a bit hard to know exactly what some item means, and necessitates of a normal cue to be reliable. But I believe that there is another innovation. Always the Toronto group introduced the Toronto structured interview for alexithymia, and this interview, I apologize for the error, consists of 4 factors that are always difficult to identify feelings, difficult describing feelings. They have reduced the items concerning the externally oriented thinking, maintaining only the items that were very strong as factors, and reintroduced another key feature of alexithymia that were imaginal processes. The daydreaming and the reduced daydreaming is peculiar in subjects with alexithymia and worthy to investigate them. And if you can train, if you can obtain the TSEA, you will see that it's quite simple, but it's less fast than self-rating scale TAS-20. But doing some practice, it will become a very important and relatively simple instrument to further assess, as I do, patients who were positive to the Toronto Alexithymia scale 20 items. When I see a patient that have a score, they have a score more than 61 or equal than 61, I administer the Toronto structured interview for alexithymia to confirm that is a subject with high level of alexithymia, and I suggest to do the same. Alexithymia is, the third reason is because alexithymia is really a relatively stable personality trait and can be not transnosographic. We have several research about this topic. This is the paper of one of the greatest researcher in alexithymia to date, that works in the University of Louvain in Belgium. This is my friend Olivier Lubinet. And it's easy to know that if you evaluate alexithymia before and after an acute stressful event, in this case in women with breast cancer, we will see that if the breast cancer is resolved, the trait of alexithymia slightly diminish, but remains almost the same. And so, unluckily, alexithymia is a relatively stable personality trait and influences negatively the presence of psychiatric symptoms, in this case, anxiety and depression in women with breast cancer. And we have demonstrated also in a chapter of this book edited by Cambridge that we wrote together with other 2 great researchers in the field of alexithymia, that are Kirsi Onkalampi and Amo Vinamaki. And we have underscored the fact that alexithymia is a relatively stable personality trait, is transnosographic, and is often an aggravating anxiety or depressive disorder, is a risk factor also in personality disorder for substance abuse, self-harm, impulsiveness, aggressiveness, and so on and so forth. But what we saw when we conducted the research, this one of my first research conducted on adolescents. They were with an average age of 15.8 years. We saw that the alexithymia, the presence of alexithymia in the baseline would be a risk factor for the onset of psychiatric symptoms or psychiatric disorders as well. We observed that the subjects were with higher alexithymic levels were more risk to be positive to back depression inventory and on SCL90 somatic scores. So they have greatest risk to develop both depressive and somatic symptoms. And so alexithymia can be a risk factor for the onset of psychiatric disorders. This is always a study of by Oncalampi and Vinamaki, and this is what we see in everyday clinical practice. When I evaluate alexithymia in my patients, I always see that there are often hard to manage patients. And alexithymia is a risk factor for major depression, personality disorder, and alcohol use disorders, or for 3 of them. And this is a very problem because to address major depressive disorder, we have instruments, pharmacological psychotherapy, as well as personality disorders, less than major depressive disorder, obviously. And also alcohol use disorder is a problem, but it cannot even be addressed. But the presence of alexithymia may not allow us to give the best treatment options, because treatment may fail in such subjects. And this is a very important point. When it's present, alexithymia may increase the severity of concomitant psychiatric disorder. We have demonstrated that in several studies. This is one of the first published in Progress in Neuropsychopharmacology and Biological Psychiatry with several researchers of my group. And we tested 145 drug-naive patients with major depression, and alexithymia subject, I apologize, I didn't translate the slide, I forgot, so I apologize. But alexithymic subjects with major depression had a higher severity of symptoms and higher CRP levels, higher suicide ideation than non-alexithymic subjects. And this issue we have further demonstrated also in patients with binge eating disorder. The other problem is alexithymia is worsening the presence of a concomitant psychiatric disorder, but can be also associated with drug resistance when treating a concomitant psychiatric disorder. This is a very interesting paper published several years ago on depression and anxiety. Here, the findings indicated that stable alexithymia features have a negative effects on antidepressant treatment in depression, but I can say you that stable alexithymic features may have a detrimental effects also on drug treatment of all other psychiatric disorders. So the concomitant alexithymia may be addressed before starting a treatment or after, immediately after starting a treatment in our psychiatric patients. And this we have demonstrated that, because we have demonstrated that even if the therapy maybe is effective, as in the study that we published on CNS spectrums 5 years ago, I apologize, we demonstrate that both MD and SHAPS decreased with the treatment with agomelatine, but the alexithymia remained quite unchanged, only slightly diminished. So the alexithymia is a very important factor in the to address when we face all kind of patients we see in everyday our clinical. The problem is not the drug therapy, it's not only the drug therapy. Several studies have demonstrated that alexithymia can also be associated with resistance to some kinds of psychotherapies when treating a concomitant psychiatric disorder. Patients with alexithymia may be particularly resistant to psychoanalysis or a standard CBT. And so we must develop, and we try to develop a newer method that that allow us to address the alexithymia before starting a CBT or a group therapy or a family therapy or a psychoanalysis and so on and so forth. And this is another problem, because alexithymia deserves a particular form of psychotherapy that is focused on emotions before trying other interventions. And this is very important for psychotherapists, because often patients with alexithymia are often discharged or drop out from psychotherapy, from psychotherapists, and this is this is very bad, because they continue to live badly. They may also develop further psychiatric episodes, maybe for the major depressive episode, and may develop alcohol use, substance use, and may also go to the development of suicide, ideation, as well as behaviors. So addressing this in psychotherapy is, in my opinion, a key factor and a crucial factor in the treatment of alexithymic patients. And alexithymia is also a risk factor for the onset of several addictions, even in the presence of the absence of other psychiatric disorder. The presence of alexithymia is related to addiction for every substances, but in particular cannabis and alcohol. There are also some studies that have linked the presence of alexithymia to increased use of psychostimulants. And this is not surprising me, because I see many patients with alexithymia that often use cannabis, alcohol, and psychostimulants to try to autotherapy and to try to make contact themselves with their inner world and with the others. And this is a problem that should be. And we have demonstrated this not only for substances, but also for behavioral addictions. I believe that alexithymia is one of the most important key psychological factors in pathological gamblers, in compulsive shoppers, and especially in the internet addiction. Moreover, alexithymia, maybe due to the above mentioned by me alexithymia stress hypothesis, is led to higher death from cardiovascular disorders in both people with psychiatric and non-psychiatric disorders. This is a very, very important issue, because the presence of alexithymia is associated with an altered dietary patterns that predispose individuals to develop the cardiovascular disorder, and the presence of alexithymia may worsen the diabetes and may lead to a more adverse prognosis when we see patients, alexithymic patients with acute myocardial infarction. This unluckily cannot be resolved only with pharmacotherapy, but it needs an integrated treatment with both pharmacotherapy, if there is a concomitant psychiatric disorder, but also with psychotherapy. Maybe it's very useful and very important when I see a patient with higher level of alexithymia, I always investigate if he was victim of a history of abuse or a neglect in the childhood age, when he was a child, when he was an adolescent, or bullying. Because the association of childhood and also adolescent trauma is quite common in subject, especially in subject with higher levels of alexithymia. So the presence of alexithymia may be an indicator of a previous history of abuse or neglect or bullying or other traumas that must be investigated when I see a patient with such characteristics. And this is always uninvestigated. It was less investigated. Few people know the link because between the alexithymia, childhood maltreatment, and suicide risk. So we try to summarize the findings in this review that we have published in evidence-based psychiatric care last year. And the 11 is because alexithymia can often be associated with a greater suicide risk. This is, we have demonstrated it in several studies. This is one of them in subjects with drug-naive subjects with first episode major depression, and subjects who were positive for alexithymia had not only a higher severity of depressive symptoms, but also a higher presence of suicide ideation and lower presence of resilience, and also on several other variables. But I believe that the very important features is the presence of the difficulty of identifying feelings and the higher of difficulty identifying feelings and are lower resilient to predict the possible development of a suicide ideation, measured in this case from the scale for suicide ideation. And we have demonstrated it further also in correlating with biological markers. In this case, it was homocysteine. And we found that higher homocysteine levels and only difficulty in describing feelings subscale or Toronto alexithymia 20 item was associated as well with higher risk to develop suicide ideation. And we conducted in 2017 in this mini review that we published on Frontiers in Psychiatry. That was quite cited and quite high cited, and it's a very satisfaction for me and for all friends who collaborated, and everybody of you should know Professor Xenia Gonda and Professor Maurizio Pompili, who collaborated this review. And we introduced the careful assessment of alexithymia in every subject with a possible suicide ideation or, in my opinion, every kind of psychiatry. The 12, and we go fast to the end, because alexithymia might decrease the coping with stress and increase the stress-related disorder. We have measured alexithymia, suicide ideation, and try to correlate also with affective temperaments and homocysteines that, in my opinion, one of the most reliable biological marker in several psychiatric conditions. And we test such variables in individuals with post-traumatic stress disorder. Well, patients with alexithymia showed increased post-traumatic stress disorder severity, a higher score on all TEMPS-A subscales, and more severe suicide ideation. Also in this study, one of the two core dimension alexithymia, in particular the difficulty to identify feelings dimension of TS20, was associated with suicide ideation in patients with PTSD. But in this study, we did not find any association between homocysteine and studied variables. And the last in the last reason, and we have a paper we have submitted to current psychiatric research and reviews, is because in general the alexithymic person lives badly, even if it does not suffer from full-blown psychiatric disorder. And I believe that trying to identify alexithymic features in the general population is very important, as Finnish do in their clinical practice. And these are characteristics of an alexithymic person, often it's male gender, low level of education, low socioeconomic levels, and mostly singles with few friends, few interests. They have poor imagination, few hobbies, mostly manual, and they suffer for a worse subjective but also real physical and mental health, and tendency to use substances, primarily alcohol and cannabis, but also psychostimulants or other substances abuse. Have diffuse somatization, but they have pure empathy, little desire to get in contact with the others, and poor adherence to medical therapies, and this is led to higher mortality levels that we have often observed in subjects with alexithymia. So I believe that these are 13 reasons that are very important to give you, and that allowed me to introduce the TTAS 20 and the Toronto structured interview for alexithymia in my everyday clinical practice. I believe that my presentation was not boring. A typical movie character that is really quite alexithymic and even psychopathic, in my opinion, is the character interpreted by Jack Gyllenhaal in the movie Nightcrawler. That sorry, there is a mistake, and there's an error in Nightcrawler word. I apologize for this. A very important movie, and you can see what an alexithymic individual can do, and too often in this case is absurd cases, I know, but it can manage people, manipulate people, and become really a psychopathic. Luckily, it doesn't happen for the majority of patients with alexithymia, but you can see in this character, very, very well played by Jack Gyllenhaal, what it means to cope with alexithymia in everyday practice. So my conclusion are there depicted in this slide, and all are in preparation, and we have submitted still in current psychiatry reviews. And this slide summarizes what I've said in the slides before. And I try to summarize this to give you a visual on what alexithymia means in everyday clinical practice, not only psychiatric practice, but also general medical practice or family medicine practice. Because if we do not address alexithymia with a specific psychotherapeutic intervention on this, that is mostly focused on emotion, to a kind of psychoeducation about emotions of the person before starting or when we have still started a treatment, is really important in everyday clinical practice. So I will thank you for attention, and if there are questions, you can forward them to Professor Smirnova, and I will be happy to answer you. And I hope my presentation will be enjoyable. I apologize for my poor English. I'm not a native speaker. And I give all of you all the best, and take care in this dark period of pandemic. Thank you very much, and thank you for your attention. This is my fantastic group of of Psychiatric Hospital of Teramo, and I work with them. Please note, there are no alexithymic in this group. There are always empathic and smiling. Thank you again.